Providers are really, really, really important in this. And this is why I talk to every single patient, every single visit about smoking. And the first time I meet them, if they're a smoker, I say, hey, I just want you to know I'm going to ask you about your smoking and how I can help every visit, because would you really trust a doctor who doesn't tell you that smoking's not good for your health? And they usually laugh, but I just sort of set the stage for that. So I'm not being a pest. Although I kind of am a pest, but that's okay, because that's what gets people to quit smoking. And sometimes I have people come back, the 6th, 7th visit, and they're like, I've been really thinking about this and I think I'm ready now. And just knowing that they can talk to me opens that door for further conversation. 3% quit per year if you do nothing. 6% will quit for 6 months with just a 3-minute counseling. And then if we do more counseling and we have more interventions, we increase that rate of quitting. We know that we have some information for patients. Cigarette smoke damages lung tissue, irritates airways, damages their cilia. We recommend that people do not quit alone. Tell people to join a support group, get some advice from somebody who's already quit smoking, ask somebody to quit with them. I have people make a list of reasons that they want to quit, pick the date to quit, and I put that right in the chart. We make a contract about what they're going to do. We make a list of triggers and think of ways to avoid them. And then we set goals and come up with rewards. Maybe all the money that they're saving from quitting, they're going to buy a new dress or go on a vacation or go out to dinner, whatever it is, that we want to have people reward themselves. And then we have people keep trying. If they don't succeed on the first time, I just say, this gives us more information about where things went awry and how we can change things. This is also a really important slide. So along with the make the patches match the milligrams, or the patch milligrams match the cigarettes, this is the other really important take-home message from this talk. So what you are seeing here is a study that shows 2 groups of people. The top row with the white circles with the black around them are people who quit smoking. So this is COPD people and their lung function over time. So at the bottom, you've got annual visits. You've got 5 years of visits on the x-axis. On the y-axis, you've got their FEV1. So people started about a 78% FEV1, and then people quit at the top open circles. So the people who quit, their FEV1 actually went up. And the numbers in the circles are those number of people. And you can see that when they quit at baseline, their FEV1 stayed higher than before they quit out for 5 years. Off of those white circles, you see some little black circles coming down. Those are people who relapsed and started smoking. And you see that when they relapsed, their FEV1 went down significantly. The bottom set of circles, the black ones with the white numbers, are people who continued smoking. And they had a baseline FEV1, and you can see that it just declined over time. But interestingly, the little white circles that are shooting off of those black circles, shooting upwards, are people who quit smoking even at year 2, year 3, and their FEV1 improved when they quit smoking. So the idea that we cannot make a difference in people's lives, even if they've got severe COPD, this study really flies in the face of that. What we see is that smoking cessation improves FEV1 up to 4 years past the study. And then it stabilized the FEV1 at that group that quit at 4 years instead of declining more. So we can halt the decline for everybody, and we can actually improve FEV1, at least in this study, for the first 4 years since the baseline. So it is imperative that we continue talking to our patients who smoke about how we can help them live better for longer without the side effects of COPD, or with fewer side effects if we get them to quit smoking.